Ladies and gentlemen, at the very outset, I would like to thank the organizers of this conference, particularly Professor Anirban Mojumdar, for having given me this wonderful opportunity to start the proceedings on this Sunday morning. I am going to talk about approach to panhypopituitarism. And I'm going to have two cases to illustrate the different kinds of hypopituitarism, panhypopituitarism that we see in clinical practice. The first would be in a young child, where it would be causes because of acquired congenital reasons, and the second would be in an adult of acquired panhypopituitarism. So the first is an 8-year-old boy who presents with growth failure, which has been noted since age 2 years, born out of full-term normal vaginal delivery, who presented with prolonged physiological jaundice. That's one of the clues of perhaps hypothyroidism or growth hormone deficiency, without any other major complications. The normal developmental milestones and good scholastic performance tells us perhaps that even if the child had had hypothyroidism, it must have been treated and corrected very well. There is no history of any suggestive of any chronic systemic illness, whether it's, say, something like celiacs, renal dysfunction, liver dysfunction. And if you look at the oxology, the height is minus 5 SDS, whereas the target height is minus 2.5 SDS. So again, in clinical practice, if the SDS is more than 1 lower than the target, then you start thinking that there is a problem and investigate. In terms of the clinical features, the typical faces, the frontal bossing, the depressed nasal bone, and mid-facial hypoplasia, all perhaps giving a clue to at least growth hormone problems, and the child is prepubertal. So when we talk about congenital hypopituitarism, you got to talk about the basic development of the pituitary, which develops from the neuroectoderm. There's gradual commitment towards the development of pituitary, the Rathke's pouch formation. Then there is proliferation, the linear precursors, and you have certain transcription factors and certain soluble factors which actually lead to this orchestrated development of the various subtypes of cells in the anterior pituitary. So on the soluble ones, as you can see, that level 1 that we are talking about, you have got BMP4, FGF8, and WNT5A. In the next level, you have BMP2 and SHH. On the transcription factor to progress to lineage precursors, you need HESX1, LHX3 and 4, PTX1 and 2, the SOX2 and the SOX3, and the OTX2. We'll talk all of these individually later on. And then for the corticotroph to develop, you need a TBX19. And you've got the prop and the PU1F1 for the gonadotrophs, and the PIT1 from the thereafter for the thyrotroph, the lactotroph, and the somatotrope. Additionally, for the gonadotroph, as well as from part of the adrenal, you will need the DAX1, SF1, and amongst the transcription factors, you need NR5A1 and NROB1. And of course, the GATA is also important for all of those 3 interactions that has been shown in this particular slide. So if you look at the sequence of development, at about 3 weeks, you have the Rathke's pouch becomes evident. By week 7 in the embryonic age, the pituitary vasculature starts to grow and begin. The corticotrophs express ACTH. At 8 weeks, the GH expression starts. At week 12, TSH and gonadotrophin expression starts. By week 20, the entire hypophyseal portal system starts. And week 24, the lactotrophs start expressing prolactin. So if you classify congenital panhypopituitarism, you can think of them as syndromic hypopituitarism, non-syndromic combined pituitary hormone deficiencies, or you can think of isolated pituitary hormone deficiencies. Because we are talking predominantly of panhypopituitarism, we could probably talk about more about the first 2 groups rather than the isolated ones. And if you look at the syndromic ones, you can see the HESX1, LHX3, LHX4, SOX2, 3, PTX1, 2, and horoporoncephaly. So if you have somebody who presents with hypopituitarism with midline abnormalities, one of the things that you got to think of is SX1 mutation. And it's one of the earliest markers of pituitary development and is essential for development of the pituitary and forebrain, the transcriptional repressor of PROP1, and manifests usually as with isolated growth hormone deficiencies, or it can have combined pituitary hormone deficiencies to septo-optic dysplasia. And if you do an MRI, you will probably find a hypoplastic pituitary, ectopic pituitary might be seen, and you might find a genesis of the corpus callosum. It constitutes less than 1% of all septo-optic dysplasias. Now, when do we call something septo-optic dysplasia? When you have any two of the three, that is optic nerve hypoplasia, midline forebrain defects, and pituitary hypoplasia with variable grades of hypopituitarism. And the endocrine manifestations can range from isolated growth hormone deficiency to panhypopituitarism, and the genes involved, majority not identified, but SX1, SOX2, and SOX3 are the ones that have been blamed. And the main clinical findings would be hypopituitarism. Like I said, GHD would be the commonest. You might have visual abnormalities, and you can have even other neurological problems like seizures, developmental delays, and cerebral palsies. This is a typical picture of the MRI of septo-optic dysplasia. The posterior pituitary, you can see probably here is where the bright spot is. Anterior pituitary hypoplasia, pituitary as you can see here is not seen. The infundibulum is absent, and absence of septum pellucidum associated with optic nerve hypoplasia. You don't see the septum pellucidum here. And if you're looking at someone with hypopituitarism with spine abnormalities, you can think of the LHX3 mutation and the LHX4 mutations on either side. Look at the extrapituitary features, which might actually help you to identify that which of these subtypes of mutations you are actually dealing with. The deficiencies can be variable, ranging from growth hormone, TSH, ACTH deficiencies, plus minus gonadotroph abnormalities. Next, if you're looking at hypopituitarism with ocular defects, you can either think of SOX1, OTX2 mutation, or the PTX2 mutations. Coming to the PROP1 mutation, which is probably the commonest genetic cause of combined pituitary hormone deficiency, is expressed within the Rathke's pouch, appears at around embryonic age 10 weeks, peaks at 12 weeks, and disappears at around 15.5 weeks. It acts as repressors of SX1, an activator of PO1F1, and leads to variable amount of gonadotroph deficiency, but growth hormone, prolactin, and TSH usually consistently are abnormal. ACTH deficiency has also been documented, often which is much later onset, and pituitary MRI usually small or normal. The PO1F1 mutation is expressed relatively late, persists throughout postnatal life and adulthood. It can be either autosomal recessive or autosomal dominant. Growth hormone and prolactin deficiencies occur early in life. The TSH deficiencies occurs in later childhood, and adult onset hypogonadism has also been reported. So if you look at an approach of hypopituitarism in infancy, there are certain clinical challenges because they may present with non-specific symptoms. They might have midline defects or ocular defects, which will act, or even skeletal defects, which might help you to figure out which of those transcription factors or soluble factors are a problem. Sometimes these hormone deficiencies will develop over a period of time. And remember, many of these stimulation tests are contraindicated, and we are often not sure what cutoffs to use to diagnose these individual hormone deficiencies. In general, the symptoms might be hypoglycemia, could be poor weight gain, failure to thrive, developmental delays, and nystagmus, and often prolonged cholestatic jaundice like the child that I described in this case 1. In terms of specific symptoms or suggesting more of specific axes that go wrong, temperature instability would be more likely to be associated with TSH deficiency, hemodynamic instability more likely to be associated with ACTH deficiency, undescended testes with gonadotroph deficiency, microphallus either gonadotroph or GH abnormality, and midline defects is associated with combined pituitary hormone deficiency. In terms of the investigations, if you're thinking of ACTH deficiency, remember in such circumstances, hypoglycemia-inducing tests like ITT is contraindicated. Synacthin test has a sensitivity of around 80%. CRH test is something that we are unable to do in our clinical setup. In terms of TSH deficiency, remember, do not go by TSH to diagnose central hypopituitarism. hypothyroidism, use total T3 and free T4 level. Additional pituitary hormone assessment is necessary because in a majority of them, they have other pituitary hormone deficiency as well. In terms of growth hormone, first 1 month of life, random growth hormone can be evaluated for growth hormone deficiency. Growth hormone provocation test might be contraindicated because of several of the reasons that I've discussed. Low growth hormone during spontaneous hypoglycemia is thought to be useful, but what cutoffs do we use? We don't know. Low IGF-1 and IGF-BP3, in addition to other pituitary hormone deficiencies, might suffice to diagnose additional GHD. So the challenge and the problem more is if you have isolated GHD. In terms of gonadotrophin deficiency, it's best if you are able to utilize that window of opportunity of mini puberty. Unfortunately, most of our patients present late when it becomes much more difficult to diagnose. But if the patient does come early, you have the option of even doing a GnRH stimulation test, blunted response of FSH and LH, you can think of is an abnormality to diagnose gonadotrophin deficiency. In terms of central diabetes insipidus, early morning paired serum and urine osmolarity. So if you see the serum osmolarity is high, with the urine not being able to concentrate, that would help. Typical water deprivation test, which we do in adults, is something that we would want to avoid. Tests in patients with symptoms or with midline defects is something that might be indicated. In terms of the MRI, look at the size of the anterior pituitary, the presence and the location of the posterior pituitary, the presence and the morphology of the infundibulum, the presence and morphology of the corpus callosum and septum pellucidum, the appearance of the optic nerves and the chiasma and associated brain abnormalities. These are all things that you should carefully look at in an MRI. As you can see here, we've tried to show here that if you have an ectopic posterior pituitary, think of HESX1, LHX4, OTX2, and SOX3. If the anterior pituitary is hypoplastic, again think of HESX1, LHX3, 4, SOX2, 3, OTX2, PROP1 and PRO1. If there is agenesis of the corpus callosum, think of HESX1, SOX2, and 3. And there might be certain other associated brain abnormalities that you should be trained to look at. And here you, for example, you can see there might be absence of septum pellucidum. There might be absence of optic nerve or optic nerve hypoplasia. So these are things that you've got to look at in an MRI when you see someone with hypopituitarism. Coming back to our case, patient had lowish normal thyroid free T4 level. The TSH was lowish normal. Cortisol was around 8.7. Prolactin was normal. And you can see typically the IGF-1 and the IGF-BP3 both being abnormally low. So you have a diagnosis of growth hormone deficiency, and possible along with that, the cortisol might have to be tested again to figure out whether there is any cortisol deficiency in addition, but in all likelihood, this is going to be an isolated growth hormone deficiency. So to look at that, you did a clonidine stimulation test, which shows that the GH does not rise. So growth hormone deficiency is documented in the presence of a normal thyroid level and not a contraindication for cortisol level, and ITT was done. The growth hormone did not increase. The cortisol levels reached somewhere around 17, telling us that perhaps there is no abnormality in the cortisol axis. And this is the image of the hypothalamic pituitary region, which shows, that the posterior bright spot is there, the anterior bit is relatively visible. Coming to the case 2, a 30-year-old man, a field worker, was bitten by a snake. Villagers said that it was a Russell viper. So this is a vascular toxic snake bite. And there was some delay in receiving the anti-snake venom. The patient had an acute kidney injury, had bleeding diathesis, underwent dialysis. And in hospital and after discharge, the patient started having history of hypoglycemia, lethargy, weakness, and features suggestive of hypogonadism as well. So if you look at acquired causes of hypopituitarism, that would include features suggestive of adrenal insufficiency, hypothyroidism, hypogonadism, growth hormone deficiency, or even rarely diabetes insipidus. So this could happen because either you have a reduced or destroyed secretory capability. like for example, in a vascular toxic snake bite, the anterior pituitary might get destroyed. It can be because of some kind of a tumor or a space occupying lesion as well. And we probably underestimate the number of cases of hypopituitarism that we actually see. And a lot of patients go from, get undiagnosed, some kind of hyponatremia that the patients have, who often have this manifestation when they get admitted in hospitals. So that's pretty common in hospital settings. And if you look at the etiology, first of all, of course, like I said, it could be because of a neoplastic reason, or it could be, some surgery, some radiotherapy, infiltrative or inflammatory disease, infections, vascular, or traumatic. So etiology can be very, very varied, which is very difficult to actually cover in a talk like this. And in terms of the symptoms, you could have certain generalized symptoms of the skin, and cardiovascular, pulmonary, gastrointestinal, muscular, renal, and reproductive symptoms. So it will all depend upon the permutation and combination of the pituitary trophic hormone deficiency that the individual actually has. So careful history taking is important, backed up by appropriate investigations of the lab. In terms of the central adrenal insufficiency, it can be secondary when pituitary disease causes abnormalities in ACTH or CRH release. For example, after pituitary surgery in, say, craniopharyngioma, someone's had a cranial irradiation. And when this will happen will depend on the etiology. For example, even with snake bite, it might happen after a few months. With the radiation, it may take years to develop, and the tumors might be relatively more slowly progressive in terms of manifestation. And often, it will need some kind of a stressful situation for it to get precipitated. So if someone has got cortisol levels less than 3 microgram per deciliter, then it's possible that this individual has central cortisol deficiency, whereas a value more than 15 often excludes, and a value in between will need other tests on clinical circumstances to tell us whether this is actually adrenal insufficiency. In terms of central hypothyroidism, it can be very treacherous because a lot of people tend to screen for thyroid disorder with a TSH only, and the TSH might be within normal range or even slightly raised rather than lowish. So don't go by the TSH per se. Remember that majority of those with central hypothyroidism will have other adrenal hormone deficiencies as well. And this can happen either because of, any tumors, radiation, and post-surgery. And go by the total T3 and the free T4 rather than TSH. There's no dynamic testing that is suggested for diagnosing central hypothyroidism. Central hypogonadism, again, very common because perhaps the LH and FSH are going to be the first to be affected, whether you're talking about cranial irradiation or a mass, and often associated hyperprolactinemia that might be caused by, say, a prolactinoma might be the cause for the associated hypogonadism, or you might have a somatomammotrough, which might actually also lead to hypogonadism because of the prolactin secretion. Untreated hypogonadism deficiency itself has been associated with increased cardiovascular mortality. In men, you tend to look at low testosterone levels combined with a low LH-FSH. In female, it becomes more difficult. Maybe you go for withdrawal bleeding with a progesterone and find that the individual is not responding, but responds to a combined estrogen progesterone. That might be one of the ways of diagnosing central hypogonadism. Hypogonadism in males, like I've already said, you go for a test for an LH, FSH, and testosterone to diagnose central hypothyroidism. In terms of women, it becomes sometimes more difficult to diagnose. Diabetes insipidus, again, it will depend on the etiology. In most of the conditions which affects only anterior pituitary, the posterior pituitary might be spared, but some of the diseases might affect both, or you might even have isolated central diabetes insipidus. We tend to look at a cutoff of 50 ml per kilogram of body weight for 24 hours is what is defined as polyuria in adults. And you're trying to look at that the serum osmolarity is more than 295 with the urine osmolarity less than 600. And I'm not going into the details of a water deprivation test, but it should be done in wherever circumstances that you are thinking that there is a possibility of a diabetes insipidus where the baseline plasma and urine ratio is not more than 2. In terms of adult growth hormone deficiency, this is perhaps a less understood and less diagnosed clinical circumstances. The tests are variable, but our major challenge is even if we diagnose adult GHD, our patients are usually not able to afford GH therapy. And prolactin deficiency might report with lactational failure in patients with Sheehan syndrome. So I've tried to actually talk about all of those aspects of panhypopituitarism in adults as well. Again, for these individuals, you've got to go for a focused MRI of hypothalamic pituitary region to detect any mass lesion, any bleed, or presence of empty sella, which is probably very, very common in our clinical setup. A non-contrast CT may also help us in acute emergency setting to see if there is any pituitary apoplexy. I shall stop there. Thank you very much for the opportunity.
Thank you, Sujay. I think it is supported by the lupin, this talk.